Hello, everyone. My name is James Waters. I'm a current third-year medical student at Cooper Medical School of Rowan University. It's located in Camden, New Jersey. And I'm also an executive board member of SNaHP. I'm here to talk about Medicare Advantage. But before I do that, I wanted to tell a story about why I'm so passionate about Medicare Advantage. Um, and we'll go back to 2006. My grandmother was diagnosed with primary light chain amyloidosis. At the time, she was given around 2 to 3 years to live. I didn't learn this until later, but she had just come to the age where she was able to be assigned to Medicare. And because of that, she didn't have to, sell her house, all of her possessions, the place where she'd have so many memories with all of us in order to be able to afford to live. And because she was on Medicare, she was able to live for 12 years past that initial diagnosis. So, that's why I'm so passionate about what, is going on with Medicare and why I really want Medicare Advantage to stop doing what they're doing. So, without further ado, let's get started. So, traditional Medicare is simple and efficient, as you may already know. But what you basically do is you just pay taxes, you get the insurance card, and Medicare pays the doctors. There's no middleman involved here. Contrast that with Medicare Advantage, it's complicated and inefficient. You can already see that this slide is already more complicated than the previous one, right? So you get the insurance card, right? But then Medicare pays all of these insurance companies, and then they pay their own contracts to doctors and then limit their networks within their contracts so you can only go to certain doctors. And it's important to remember that Medicare Advantage is not Medicare nor an advantage for all of these reasons. And that's what we'll discuss during this presentation. Here's all the reasons here on why it's not Medicare. And all those things we're going to talk about. So first off, Medicare Advantage plans are expensive to operate. The overhead here, which is the percent of premium that's not spent on medical services, is stupidly high. All the corporate machines that we hate are here. You can see it's Cigna, United Healthcare, Aetna, all of them, and then they're doing nothing different in Medicare Advantage. Contrast that with traditional Medicare. It's night and day. It only has a 2% overhead in traditional Medicare, and we are around 9 times that for the highest in Cigna United Healthcare. And Advantage is the big corporate money maker, right? So when we look at gross margins per enrollee, which is just the profit per enrollee, you can see in Medicare Advantage, it's double all of these other types of markets. It makes it worse when you realize that companies like Humana are cutting out lower margin businesses. They're cutting out their individual market for public funded markets entirely and trying to exclusively use their high profit programs. These gigantic margins are the big driver for Advantage to take over traditional Medicare, and it's no wonder they're trying to get people to join, which is resulting in high numbers of enrollment. Here, we now see that Medicare Advantage has captured a majority of Medicare beneficiaries, and this chart from MedPAC shows that now over half of eligible Medicare patients are now in Medicare Advantage plans. You look at this trend, it speaks for itself. In less than 20 years, we've basically gone from 1 in 5 people to now 1 in 2. And now by 2028, it's projected to be even higher, right, up to 60%. And there's lots and lots of people joining, and then this whole presentation is designed around why that's a bad thing. But before we understand why Medicare Advantage is bad, we have to understand how Medicare Advantage works in the first place, right? So it begins with the Center for Medicare and Medicaid Services, CMS, right, creating an average cost of care per traditional Medicare patient. That per person average is the starting point for the benchmark, right, that Medicare Advantage plans have to compare to. After the benchmark is determined, each Advantage plan submits a bid to CMS for how much they think they can deliver the same benefits as in traditional Medicare. And if they bid below the benchmark, they are allowed to retain roughly 2/3 of the gap is in what's called a rebate. CMS gets to keep the other 1/3, but the Medicare Advantage plan is expected to use some of their rebates to either lower beneficiary out-of-pocket costs or to offer additional benefits. Conversely, if the Advantage plan bids above the CMS benchmark, they are required to charge a premium to patients to make up the difference. Now, since 2018, rebates have more than doubled, right? So these plans are incentivized basically to bid below that benchmark so they can keep a lot of that rebate money, they can make more money. And now they're pretty good at keeping below that benchmark. And you can see the exponential curve here and how Medicare Advantage plans have been able to increase their rebates, excuse me. But like, what are these rebates really used for if they're growing all the time? Turns out they're not really using them to reduce their out-of-pocket expenses. And you can see the percentage of rebates going to reducing out-of-pocket expenses is going down. Now, the Advantage plans know that reducing out-of-pocket expenses for beneficiaries, it removes financial barriers to healthcare and it allows people to use more healthcare services. They don't want you to do that. They don't want you to use healthcare services. And people getting healthcare costs them money, which is what we refer to as induced utilization. This is proof that Medicare Advantage companies like United Healthcare know that people will get the healthcare they need if they have lower copays and deductibles, but they're instead using it for something else, for keeping it or for profit. And we'll refer back to this later when we review PNHP's new report on overpayment. And in addition to that concept of induced utilization, another thing we have to understand is favorable selection, right? Which is the concept that insurers are paid for the expense of the average traditional Medicare patient, but attract the healthiest, right? They favorably select the healthiest patients, right? And if you look at the data on the right, traditional Medicare patients from 2015 that stayed in traditional Medicare into the next year had higher medical expenses in 2015 than those that switched to Medicare Advantage. This shows that healthier people are the ones that switch into Medicare Advantage, and those plans have become really good at attracting healthier people into their system that use less benefits and are therefore less expensive to take care of. Right, and then these two concepts, favorable selection and induced utilization are essential company strategies in gaming the system for more profits. The less money they spend on patients, the more they get to keep. Switching gears a little bit, we can see here that Medicare Advantage provides more initial home health visits. And this is like, another thing they're going to game the system on denying people care. You would think that Medicare Advantage plans would provide more continuing visits, right? They don't, right? They give you a ton of these initial home health visits while actually providing less ongoing health care. And this one visit is not for the purpose of health. It's for, you guessed it, creating profit for shareholders. And as you've already guessed, this is a common theme throughout the presentation, and it's a tactic to upcode initial patient diagnoses and increase revenue and profits while providing less actual services overall. And this is another thing we end up overpaying for in Medicare Advantage, which again will be mentioned in the new report. Keeping with the denying theme, you can see here that nearly all Medicare Advantage enrollees are in plans that require prior authorization for some services. Some that aren't on the screen here are Part B drugs, skilled nursing stays, inpatient hospital stays, hearing and eye exams, mental health and substance use abuse services. Now, all of these are services where over half of Medicare enrollees are in plans that require prior authorization to receive them. And this makes our job difficult as physicians, or me as a future physician. We're the ones that end up having to deal with these denials, and we have to work around or call and haggle over insurance and deal with, the burnout. It just makes things super, super complicated and hard, and it's really not fair. And it's important to remember that this is fairly unique to, private insurance and Medicare Advantage. Traditional Medicare does not use prior authorization except for a handful of services. And along with how patients and physicians and hospitals are struggling with delays and denials that are rampant in Medicare Advantage, in the past few months, we've seen a rapid exodus of hospitals from Medicare Advantage. You can see them all here. And part of this crisis is due in part to the aggressive rate negotiations empowered by the increased market penetration of Medicare Advantage. As Advantage plans gain market share, they become really, really powerful at the bargaining table, and they're not bargaining with our public health interests. And on top of that, look at what the departing hospital networks are saying. It's not just about the negotiated rates, but it's about the business model of Medicare Advantage companies denying necessary medical care. And as Stillwater said, this is unheard of in traditional Medicare, but rampant in Medicare Advantage. And the collapse of Medicare Advantage hospital networks is a new emerging disaster, and it's a direct consequence of the Medicare Advantage business model, and one more thing that single payer would eliminate. So, PNHP has been telling multiple members of Congress and their staff about all of the things that we just discussed. A very common response is that legislators are also hearing from the Insurance Industry Lobby Group, formerly known as America's Health Insurance Plans, AHIP, right? And these lobbyists are warning legislators that attacking Medicare Advantage would worsen health care for racial minorities and low-income Americans. And some of these members of Congress are asking us how they should respond. But in order to deconstruct that, let's look at how groups like AHIP can claim to be the solution to healthcare inequities in the first place. So they're not lying when they tell Congress and say that their plans have a higher share of people of color and those of low income. And this data will show you that that's true. Right? But they're wrong when they use this as proof that it means that they are the solution to our nation's inequities. In fact, it actually means the opposite. In short, it really means that the usual disenfranchised groups of Americans are being left with no choice but to accept a product with major problems that wealthier Americans are less likely to tolerate. You know, the higher rates of Black, Hispanic, and low-income Americans is not evidence of a solution. It's evidence of the problem that they say they address. And let me show you what I mean with some slides that you can use to educate your elected officials. So first of all, Medicare Advantage beneficiaries experience significantly more cost-related problems in accessing care. And this is more pronounced in minority populations. You know, you can see here it is more exacerbated, right? While the difference in race in both traditional Medicare and Medicare Advantage is indicative of a larger systemic problem, the fact that Medicare Advantage is exacerbating these differences tells you that Advantage is not the solution to equity. And then the same thing is true across income groups. People in Medicare Advantage have more problems with medical bills and medical debt than do people in traditional Medicare, with one exception, and you probably guessed it, right? People in the higher income brackets don't have this problem. Again, Medicare Advantage is not the solution to equity. Third, one of the more important reasons that people opt into Medicare Advantage is that they are desperate to get dental care. Medicare Advantage promises to provide them with that, but as you can see here, people in Medicare Advantage have more, not less, problems accessing dental care for financial reasons. And this data is a little bit confounded as it doesn't adjust for income, and I just showed you that people in Medicare Advantage skew towards lower income groups, but the false promise that Medicare Advantage will include good access to dental care is clearly misleading. And again, third time, Medicare Advantage is not a solution to equity. And of course, it's not just dental care that's hard for people in Medicare Advantage. It's a particularly big deal, actually a life-threatening deal for people dealing with cancer. And to start, this data shows that people in Medicare Advantage have to wait longer for cancer surgery. You know, the difference here in wait time for pancreatic cancer is particularly terrible when you consider how deadly it is. And on top of having to wait longer than people in traditional Medicare, cancer patients in Medicare Advantage are far less likely to use an NCI designated center of excellence. In other words, they are more likely to have their surgery done at hospitals that are not recognized and likely far less experienced in those complex surgeries. And it turns out that these delays of getting to treatment and this redirection to less experienced hospitals is leading to increased mortality rates. So delays in getting treated and being shunted away from America's best cancer hospitals is taking its toll on people in Medicare Advantage, resulting in higher mortality rates. And these policies are literally killing people with cancer, right? Like, what are we doing? But nobody warns people about this when they sign up for Medicare Advantage. They pay a much smaller premium than they would if they stayed in traditional Medicare and had to buy Medigap and Part D, but they're literally gambling that they'll all stay healthy. Ooh, taking a breather after that. You know, you may be wondering, right, if Medicare Advantage is so bad, it's literally killing people with cancer. You may be wondering, how are people signing up for this in the first place? Well, this is partially why. The Senate Finance Committee has started looking at the outrageously egregious ways that Medicare Advantage corporations mislead Americans. They issued a major report last year about these deceptive marketing practices, and in October of this year, they held another hearing on this. People are starting to understand that they're being lied to, and they're angry, and angry seniors know exactly how to call Congress, right? Well, let's take a look at how deceptive these practices really are. This is an example of a note from a Medicare Advantage program that looks like a federal agency. Right? Do you see the words Medicare Advantage together on this slide? And I'll save you the time. You won't, right? But seniors receive mailers that look like official business from a federal agency, yet the mailer is a marketing prompt from an Advantage plan or its agent or its broker, right? And often seniors don't even realize they just switched to Medicare Advantage and find out months later at a PCP visit, right? This is something that's like cartoonishly evil, right? You have to be twisted to think of this. It's just like I compare it to Wile E. Coyote drawing the tunnel on the wall. If you know your cartoons, it's just like out of nowhere. But again, at the end of the day, we as physicians have to manage this problem. And when patients come in to find out they're not in network anymore, the burden of explaining this to patients and helping them find out different insurance, it falls to us, and it's really a lot to deal with. And here's another example, widespread television ads that claim that seniors are missing out on benefits, including higher Social Security payments, in order to prompt seniors to call Medicare Advantage plan agent or broker hotlines, right? I feel like a lot of people have seen these ads, and again, do you see Medicare Advantage on any of these slides together? It just says Medicare, right? It's really, really misleading. And again, these ads look like Medicare, but they're not. And the phone number look like Medicare, but they're not. And to add on top of this, CMS used secret shoppers, which are people who act like they're looking for insurance but are really just recording calls. They use them to record calls and determine the accuracy of broker statements. And they found that during these calls, that 80% of the calls provided inaccurate or insufficient information, and it misleads seniors into their plans. Hear that again, 80%, right? And here's just one example of many. If your medication is not on the formulary, your doctor could tell the plan and the plan would simply add it, right? That's just laughable, right? It's clearly a lie. And so many people who work in different clinics know that it just isn't the truth. And all of these are documented examples of deceptive Medicare Advantage marketing practices that this report from the U.S. Senate Committee on Finance found. This erodes trust in the program and undermines access to care within the Medicare program. And while CMS has taken steps to help with these matters, Medicare oversight deteriorated significantly during the Trump administration, which led to key protections against these predatory practices being taken away. And just last month, I'll mention this again, there was a hearing, or excuse me, not last month anymore, it was in October. There was a hearing in the Senate Finance Committee regarding the marketing in Medicare Advantage. It appears that Congress is paying more attention to this problem, and it's part because we're causing a lot of hoopla about it. So we should really do more of the same and apply the pressure. And if those predatory practices weren't enough, brokers that help beneficiaries choose the right coverage are incentivized to bring seniors to Medicare Advantage, right? However, these commissions are significantly higher in Medicare Advantage when compared to other coverages, and it's increasing while the others are decreasing. This shows that profit incentive runs deep. It's important to know that about a third of seniors turn to brokers for their insurance, and they claim to be non-biased, but they don't disclose these profit incentives at all, which is further evidence of corruption. And important to note, the difference in commission of like $100 for one guy, right, is a drop in the bucket compared to the absurd profits and overpayment that Medicare Advantage companies like Cigna and United Healthcare are receiving. It's another thing that we're going to talk about in the new PNHP report. So again, if it's so bad and it's so deceptive, why do so many people sign up for Medicare Advantage, right? And in addition to being deceived into joining, traditional Medicare is imperfect, right? There's a 20% outpatient coinsurance charge, a $1,600 hospital deductible, and no set out-of-pocket limits that burden seniors when they make their much-needed visits. In addition, they need to purchase multiple parts of Medicare, each with their own premiums. So they're really left with three options. They can keep traditional Medicare, do nothing, and risk bankruptcy. They can leave traditional Medicare and sign up for Advantage, or they can keep traditional Medicare and maybe purchase Medigap. But let's just do a little bit of head-to-head and determine, what people are looking at when they're signing up for these different insurances, right? So we compare Medigap, traditional Medicare. Medigap has no additional benefits beyond traditional Medicare, but you can see here, Medicare Advantage offers all of these really actually good benefits, right? Hearing, vision, dental, gym clubs, all these things. Someone who doesn't have a very in-depth knowledge about a lot of this insurance stuff will see that and say that's a really good thing. You can see here, though, that Medigap has the advantage when it comes to out-of-pocket expenses, right? There's zero out-of-pocket after the Part B deductible, but you can get hit pretty hard with out-of-pocket expenses in Medicare Advantage, right? In utilization management, we already talked about this. Medicare Advantage has a lot of prior authorization, step therapy, all of that kind of stuff. So again, the advantage is in Medigap. And Medigap networks are identical to traditional Medicare, where in Medicare Advantage, we talked about this already. There's a lot of smaller, narrow, like variable lists of in-network physicians and hospitals. But looking at the premiums, and this is a very big deciding factor for most people, it's a lot cheaper in Medicare Advantage. So that's where they decide, that and the benefits is where they decide to go to Medicare Advantage, right? Some people might not have enough money for traditional Medicare and Medigap, so they can switch to Medicare Advantage, right? You can see here that it's almost half, or it is half actually, but there are some concerns, and it's our job to educate people about those concerns. But when a lot of people sign up for this insurance, they say, I'll start with Medicare Advantage and only go back to the traditional Medicare if the plan won't let me see the doctors and hospitals that I want. What's the worst that could happen? I'll tell you. Federal protections for people's pre-existing conditions end after 6 months in Medicare Part B or 12 months in Medicare Advantage. So after 12 months in Medicare Advantage, federal protections for pre-existing conditions end. People get trapped with all of those problems mentioned before and don't even realize it. And this is because of two issues right now in insurance. So due to ACA marketplace protections, if you buy insurance on the marketplace, insurance agencies have to sell you insurance, which is called guaranteed issue, and they have to sell you insurance at the same rate as everybody else, which is called community rating. Both of those protections exist for people under the age of 65. However, after age 65, this protection disappears after 12 months, and you don't have those protections. There's no guarantee that you can get Medigap coverage because it will send you a health questionnaire to either deny or upcharge your care, right? So, for example, if someone gets sick after 13 months on Medicare Advantage, for example, they get cancer and the procedures and constant visits, switching back to traditional Medicare may be financially unrealistic to the disappearance of these two protections. And it's important to know that there are a few states that have extended these protections, but it's very few, and they expanded these protections decades ago. So, nothing really new has happened on this issue. Okay, moving on to the big kahuna. This is the new PNHP report. So a lot of the previous slides show who Medicare Advantage hurts, but this new report is showing who it helps. And spoiler alert, CEOs and shareholders are mostly the ones that are getting helped by this. You can get the full report at pnhp.org/MA report or by scanning this QR code, which will also be available at the end of the slideshow. To get started. So why PNHP did this study? Like any other study, we noticed a gap in the literature, right? We saw many studies identifying individual components of the ways that Medicare Advantage plans are overpaid, but we'd not found any place where all of these factors were rolled up together into one overall calculation, so it was impossible to grasp the real scope and context of the damage being wrought by Medicare Advantage. And without a combined number, it's really, really hard to grasp how big the problem really is. And we had also seen a lot of statements like this one from Kaiser and others from MedPAC consistently describing the failure of Medicare Advantage to save money and, in fact, only increasing the cost of healthcare within Medicare. So we decided to not recreate any of that really robust and sturdy primary literature that dug deeply into CMS claims databases, but instead to determine the scope and context that has been missing from the national dialogue. So let's get right into it, right? So upcoding, which is adding inactive diagnoses to increase capitation rates. We are overpaying by $20 billion. Favorable selection, being prepaid for average patients but attracting the healthiest. We are overpaying by up to $46 billion. County benchmarks and quality bonuses, which are extra payments without clear value for patients. We are overpaying by up to $28 billion. Add that all together, it is a subtotal of up to $104 billion of overpayments. When you add in induced utilization, which is overpaying Medicare Advantage plans as if they removed financial barriers to care, despite that not being true, you add $36 billion to that total, leading to a total overpayment of up to $140 billion per year. Again, $140 billion per year. So what would you do for $140 billion per year? Right. So PNHP's estimate of dozens of economic analyses reveals a range of $88 billion to a reasonable upper level of $140 billion. And, for all of the things we've talked about, we probably think that $140 billion is pretty conservative, probably a low ball. But is $140 billion a really big number in the scope of something so big as a federal budget? So it really helps to add a little bit of context to this. So to start, a shocking number emerged when we looked at the premiums paid by virtually all seniors and the people with disabilities for Medicare Part B. Most pay about $170 a month, and most just have it taken out of their Social Security check. They know it's there, but they usually don't really see it. It's kind of invisible. If you add up all of those monthly $170 payments by millions of people, that's $131 billion across the country every year. That is less than the money being grifted by Medicare Advantage corporations. Medicare members all pay that because they're being told that it's the only way the federal government can afford to provide a Part B benefit. I believe they'd be pretty angry if they realize that Medicare Advantage profiteers are diverting all of those premium dollars being taken out of their Social Security checks every month. And increasing their checks by $170 a month would be a big win for people in Medicare and for the politicians that make it happen, right? And one of our projects is to make sure that this is widely understood. People would be pretty angry about this if they knew. Or if you remember all of the controversy and fighting over Medicare Part D, the entire federal spend on Part D is less than our estimate of the overpayments to Medicare Advantage. Or one of the things we really need to do to improve traditional Medicare and level the playing field against Medicare Advantage is put in a maximum out-of-pocket cap, right? Those copays and deductibles can quickly bankrupt people, and there's no limit to that in traditional Medicare today. And that's why people have to buy Medigap if they can afford to, or go into Medicare Advantage and risk not getting the health care that we need, or they need. So if we limited the out-of-pocket risk in traditional Medicare, we'd help people avoid Medicare Advantage. And of course, PNHP would like to see that out-of-pocket max set at 0, but there's some more modest estimates out there, like the one from Urban Institute, that put it out at $5,000 per year. And even that would cost a tiny fraction of what Medicare Advantage drains from us and would go a long way towards leveling the playing field. Finally, we could add the missing benefits that most people really want, like dental, hearing, and vision. Medicare Advantage corporations market the hell out of those things, and people join Advantage to get those benefits, and then later find out how limited the benefits really are. And it turns out that adding dental, hearing, and vision, not just to Medicare, but even to all of Medicaid, would cost less than our lowest estimate of the overpayments. There's a couple more things you could do with $140 billion per year. One thing, more things to kind of put it into scope. You could buy up to 70 billion slices of pizza. And I know for some of us who live in cities, $2 per slice is really, really cheap. It's probably up to $4 per slice now. But I've also seen some bars in the city with $2 beers. So, win-win situation there. But there's probably some better things we could do with $140 billion per year than 70 billion slices of pizza or 70 billion beers. One thing we could do, and I think this is probably the best idea, is eliminate all medical debt in 18 months. Sounds like a better idea, don't you think?